Hello everyone, this is Dr. Hanifa and in this video we'll discuss about the normal chest X-ray. The topics which we'll be covering in this video are different types of shadows that are produced by different structures in the chest like bone, fluid, soft tissue and ear. We'll also discuss about the different views taken like posterior anterior view, anterior posterior view and lateral view. Next is the level of exposure, rotation of the chest X-ray, lung fields that includes different zones of the lungs and bronchovascular markings. Other things which we'll be discussing is the cardiac silhouette, cardiac size, borders and about diaphragms and subdiaphragmatic structures. So let us start with the different shadows produced by different structures. Remember one thing, that is the most radio-opaque structure, it produces white shadow, and the most radiolucent structure produces black shadow. So you can see here in this image that the air which is the most radiolucent is producing black shadow. The fat appears dark grey in color, soft tissue gives rise to grey, bone appears as off-white, and metallic structures appears as bright white color. Let's see one example. This is a case of left pneumothorax in a patient having pacemaker in situ. We can see the pacemaker, which is a metallic structure, is producing bright white shadow. Bones, for example, this vertebra is producing off-white shadow. Lung tissue in between the ribs is appearing as gray shadow. In this example, it is a air-filled pleural cavity due to pneumothorax and it is producing black shadow. The opacities of the lung, they are classified as homogeneous or non-homogeneous. So the homogeneous opacities are uniform in density as you can see in this X-ray. And in the non-homogeneous opacity, the density is not uniform as you can see here in the right upper lobe. Coming to the different views of the chest X-rays. Now first of all, what is X-ray view? X-ray view means from which direction the X-ray has been delivered and what was the position of the patient during the X-ray. There are many views for the chest X-ray, but the most commonly advised views are posterior anterior view, that is PA view, anterior posterior view, that is the AP view, and lateral view. As you can see here, in the posterior anterior view, the patient is asked to stand in front of the X-ray recording plate facing towards the X-ray plate, and the X-ray beam is delivered from the back. Patient keeps his both hands over the waist and rotate his shoulders anteriorly so that the medial margins of the scapula will be away from each other and the scapular shadow will not fall over the lung fields. However, as you see here in the anterior-posterior view, the patient may lie either supine or in the standing position. Here in this picture, the patient is lying supine. The X-ray recording plate is placed posterior to the patient and the X-ray beam is delivered from the front. Or you can say, since it is supine, it is delivered from above. There are some differences between posterior anterior view and anterior posterior view of the chest X-rays. In the PA view, that is the posterior anterior view, cardiac shadow is relatively smaller in comparison to the AP view. Clavicles are slightly angulated in the PA view, but it is almost horizontal in the AP view. If you notice further, the medial margin of the scapula is away from the lung fields because of the positioning which is taken care while taking the X-ray. But in case of the AP view, it falls over the lung fields. The lateral view of the chest X-ray is done in standing position. Here the patient will stand in front of the X-ray recording plate with one lateral aspect of the chest will face towards the X-ray source. and another side will be facing towards the X-ray recording plates. The other views which sometimes are sought for are lateral decubitus, which may be right lateral or left lateral decubitus, and the apical view. Now coming to the exposure of the X-ray. In case of the normal exposure of the chest X-ray, the bronchovascular structures are usually visible within the cardiac shadow. Intervertebral space can be seen in the upper thoracic region, but the lower thoracic T8, T9 vertebra should be just visible, not distinctly through the cardiac shadows. Then now what happens in the underexposed chest X-ray? If you compare the normal and the underexposed, the lower part of the lung fields will be hazy. You cannot see here the bronchovascular markings over the cardiac shadow. Upper lobe bronchovascular markings, it becomes more prominent in the underexposed view. And also the upper thoracic vertebra will not be seen distinctly. In overexposed chest X-ray, now what happens in the overexposed, the lung fields become more darker. If you compare with the normal chest X-ray, it is appearing more black. There will be obliteration of the bronchovascular markings and the vertebral bodies behind the cardiac shadow becomes more prominent. To see whether the chest X-ray is done with the proper positioning or not, to check for any rotation, you first identify the medial end of both clavicles and measure the distance between the medial end of both the clavicles and the spinous process of the T4, T5 vertebra. It is equidistant in both the sides. Then we call it a central position, or otherwise there is some rotation of the patient. Now coming to the reading of the chest X-ray. First of all, that you should keep in mind that the chest X-ray should be always read in a systematic manner. We should always start with the examination of the patient's detail, which is usually at the top corner of the X-ray film. The side of the X-ray will be marked at the top of the either corner with letter L for left and letter R for right. Once you identify the person details and the X-ray side of the X-ray, then we should look into the lung fields. The lung fields should be scanned from top to bottom and on both the sides, giving some extra emphasis on bronchovascular markings and the lung margin. Next, you go for the examine the size and the position of the cardiac shadow. Look for the position of the trachea that can be easily seen as a black shadow that is produced by the air column within the trachea in the upper mediastinum. See the cardiophrenic angle on both sides and also the costophrenic angle as you can see here. Then you scan thoroughly the bony thorax on both the sides after you check for any soft tissue shadow outside the bony thorax. At last, look for any other findings like intercostal drainage tubes, pacemaker, mechanical cardiac valve, central venous line, or any other important pathology in the chest. In this slide, we will see how we can identify the ribs and count them in the chest X-ray. First of all, we should identify posteriorly the transverse process of first thoracic vertebra. From this point, we can trace the ribs from posterior to anterior. We can then count them from above downwards. Posteriorly, if you see, the ribs are more horizontal, and as they come anterior, it becomes more oblique. The lung is on each side, the lung is divided into three zones by two horizontal lines. The upper horizontal line passes from the inferior margin of the anterior end of second rib, and the lower horizontal line, it runs from the inferior margin of the anterior end of fourth rib. So, the upper zone of the lung starts from the apex to the upper horizontal line. The middle zone of the lung it lies between the two horizontal lines, and the lower zone is below the lower or the second horizontal line. Look for the costodiaphragmatic angle and the cardiodiaphragmatic angle on both sides. Remember that the costodiaphragmatic angle is also called as costophrenic angle. This costophrenic angle is the most dependent part in the standing position. So, if there is any free fluid in the thoracic cavity, it will be first accumulated here in this angle in standing position. Next is regarding about diameters and the heart size. To measure the cardiothoracic ratio, first you should measure the transverse diameter of the heart. For this, draw a vertical line over the middle of the heart and measure the maximum distance between this vertical line and the lateral margins of the heart on both sides. The cardiac diameter will be the sum of these two measurements. If, for an example, here if you see, we have drawn a line vertically through the middle of the cardiac shadow and we have marked it as A and B. So the cardiac diameter will be A plus B. Then we will measure the maximum internal diameter of the thorax. Usually it lies over the costophrenic angle. So now we have the internal diameter of the thorax as C. So now we can measure the cardiothoracic ratio. It is calculated as A plus B divided by C. In a normal healthy adult, the cardiothoracic ratio is less than 0.5. As we have seen the cardiac size and the cardiothoracic ratio, let's see what is a cardiac cell count. On the right side, the upper straight part of the cardiac border is formed by superior vena cava and the ascending aorta, and the lower convex border is formed by the right atrium. The left border of the heart from the above downward is formed by prominent aortic knuckle, the main pulmonary artery, left atrial appendage, and left ventricle. Coming to the diaphragm, we have two domes of diaphragm. The right side of the diaphragm is placed up to 2.5 cm higher than the left side in a normal chest X-ray. The right side of the diaphragm is crossed by the interior part of the sixth rib, but the posterior aspect of the 10th rib can be counted above the diaphragm. We can also see some gas shadows below the diaphragm on the left side, which is formed by which is due to the gas in the gastric fundus and colon. Thank you. If you like this video, then kindly share with your friends. You can also see other videos for medical undergraduate in our YouTube channel, Undergraduate Medicine Clinics. Thank you.